Slide
Yes, sir.
आइरहेछ है. So come to now the hospital-acquired pneumonia. So this is very common, so that we are going to encounter in our clinical practice. Okay, so that's regarding the community-acquired pneumonia. So what's the hospital-acquired pneumonia? So I'm going to shortly finish up this within 3 to 4 slides. Okay, admit कर दिनुहोस्. So what is hospital-acquired pneumonia? So it's a nosocomial pneumonia or hospital-acquired pneumonia is defined as a pneumonia that occurs, okay, so 48 hours or more after the hospital admission. So hospital admission, so patient might be admitted with other things, okay, just like patient might be admitted with appendicitis, and after admission of 48 hours, if the patient develops pneumonia, okay, so that is known as a hospital-acquired pneumonia. So similarly, so what is the ventilator-associated pneumonia? So ventilator-associated pneumonia is a pneumonia that occurs more than 48 to 72 hours after tracheal intubation. Okay, so and is thought to affect the 10 to 20% of the patient receiving the mechanical ventilation for more than 48 hours. Okay, so 48 hours. So if the patient is been electively intubated, because if the patient is of the trauma, if the patient has a GCS Glasgow coma scale of less than 7. Okay, so if the patient has a head trauma or traumatic brain injury, and the patient was admitted and patient was intubated electively to prevent the aspiration, and patient on the ventilator, and after 48 to 70 hours the patient might develop pneumonia. Okay, so on the ventilator, then we can say this as a ventilator associated pneumonia. Okay, and then if the even for the any medical cases, if the patient is been admitted, but now after recovering again after 48 to 70 hours, we are seeing the new patch on the chest x-ray in the patient with the ventilator, then pneumonic patch, then we can say this as a ventilator associated pneumonia. Okay, so ventilator associated pneumonia. So why it is important to know this? Because it is the organisms which you are going to get in the hospital acquired pneumonia and the ventilator associated pneumonia is different than the organisms which you are going to get in the community acquired pneumonia. So that's why we should know about that, and the organisms and the treatment protocols. Okay, so what are the non-MDR pathogens that we are going to get is mainly the Streptococcus pneumoniae. These are the non-MDR organisms: H. influenzae, methicillin-sensitive Staph aureus, antibiotic-sensitive Enterobacteriaceae group of. So Enterobacteriaceae is very common. E. coli also. Okay, E. coli is mainly is present in the urine and the stool. So because of all the contamination in the hospital and all these things, you can get the E. coli, and then the Klebsiella pneumoniae, Proteus species, okay, Enterobacter species, Marcescens. So all these pathogens are mainly okay, roaming around in the hospital settings. Okay, so that's why. So now it is more vigilant that so you might carry this infection with you in the home. Okay, so that's also is mainly in the fomite. All these organisms might be there. So these are the things that you have to consider also. And then the MDR pathogens. So if you are going to carry the MDR pathogens, so it's very also okay, hazardous and very deleterious effect. So that's the Pseudomonas. So Pseudomonas is mainly hospital acquired, so that we are going to methicillin resistant Staph aureus, MRSA. Okay, and then we are getting a lot of patient with the Acinetobacter. So these are the Enterobacteriaceae, and the antibiotic resistance other Enterobacter like Enterobacter. Okay, so species all are the antibiotic resistance, and even the Klebsiella. And then the ESBL positive strains and carbapenem resistant strains, Legionella pneumophilia, Burkholderia capacia, Aspergillus species. All these are the MDR pathogens that you are going to get. Okay, so these are the pathogens, mechanism, and the corresponding prevention of strategies for the ventilator associated pneumonia. So why it is mainly important is that we have to prevent that. Okay, so mainly the pathogenic mechanisms is the oropharyngeal colonization with the pathogenic bacteria. So the elimination of the normal flora is there, and large volume oropharyngeal aspiration around the time of intubation. Gastroesophageal reflux is the another one. Bacterial overgrowth of the stomach, cross infection from the other colonized patient. So from another patient also you can get. So that's why, so going to putting the chart on one patient bed and then again carrying on the chart, and you are not sanitizing the hand, you are not sanitizing your stethoscope and touching that patient, and again going to look for the another patient. So you are the culprit for this cross infection. Okay, so cross infection. So you are the carrier of this infection, and you are infecting the patient on the ICUs or in the hospital also. And then, so what is the prevention strategies? So elimination of non-flora is mainly we have to avoidance of the prolonged antibiotic course. So we are not going to give the antibiotics for the prolonged period, 14 days, 20 days, and all these things. So we have to avoid the prolonged antibiotic courses. Large volume or pharyngeal aspiration around the time of intubation. Short course of prophylactic antibiotics for the comatose patient can be used. And gastroesophageal reflux is mainly the another one is post-pyloric internal feeding, avoidance of the high gastric residuals, prokinetic agents, so that can be used on this gastroesophageal reflux. And bacterial overgrowth of the stomach, avoidance of the prophylactic agents that raise the gastric pH, selective decontamination of digestive tracts with non-absorbable antibiotics is the another one that you can use is as a prevention strategies. And cross infection from the other colonized patient, hand washing, as I told, especially with alcohol-based hand rub, intensive infection control education, isolation, proper cleaning of the reusable equipment. Okay, so that's mainly advisable for to prevent this hospital-acquired pneumonias. So large volume aspiration, you can keep on the endotracheal patient and the endotracheal intubation, rapid sequence intubation, technique, avoidance sedation, decompression of the small bowel obstruction, and then the micro aspiration around the endotracheal. So this chart is given in your Harrison. Okay, so this is from the Harrison 23 edition. You can look on that. And then the endotracheal intubation you can do for non-invasive ventilation. On that case, if possible, you can use the NIV. Prolonged duration of ventilation, daily awaking from the sedation, weaning protocols that can be used. Abnormal swallowing function, early percutaneous tracheostomy that you can advise if the patient has a difficulty in swallowing and there is signs of aspiration. And then the secretion pulled above the endotracheal tube, head of the bed elevated, continuous aspiration of subglottic secretion with a special endotracheal tube that you can use. And altered lower respiratory host deficits, tight glycemic control, lowering of the hemoglobin transfusion threshold. All these are the things that you can try to prevent the hospital-acquired pneumonia or ventilator pneumonia. So what is the treatment? So antibiotic resistance, you have to think about empirical therapy and specific treatment. So this is the recommendations for the empirical antibiotic treatment of the hospital-acquired and the ventilation-associated pneumonia. If there is no risk factors for the resistance gram-negative pathogens, then you can use the precedent tazobactam, 4.5 gram IV 6 hourly, and or you can use the cefepime, 2 gram IV 8 hourly, or levofloxacin 750 milligram IV OD that you can use. If the patient has the risk factors for resistance gram-negative pathogens, choose one from each column. Okay, so each column you can use. There is a piperacillin, tazobactam, cefepime, or ceftazidime, or imipenem or meropenem that you can use, or plus you can use the either amikacin, gentamicin, tobramycin, or you can use the ciprofloxacin or levofloxacin. Or if the patient is not improving, and then you can think about the colistin. Okay, so colistin, colistin loading dose of 5 milligram IV followed by maintenance dose of 2.5, and you have to monitor the creatinine clearance on this, or you can use the polymyxin. So now we are getting lot of these resistant organisms. So all are resistant to all these antibiotics and only sensitive to colistin, polymyxin, and tetracycline. So these three antibiotics is very costly. Okay, so it also almost costs around 50,000 to the patient, or even more, 1 to 1 lakh rupees. Okay, so that's very high. And if we are going to get the resistance to this colistin, polymyxin, and the tetracycline, then we will be we are helpless to save the patient. So that's very important that we should prevent the antibiotic resistance. We are getting a lot of antibiotic resistance. Okay, so this is very dangerous situation. And if along with that, if you are thinking of MRSA, then you can either use the linezolid, or you can use the vancomycin. So if and also we are getting the vancomycin resistance. So in that case, you are going to use the linezolid 600 milligram IV 12 hourly. So this is the how you are going to treat a patient with hospital acquired and the ventilator associated pneumonia. Okay, so this is the recommendation by ATS and IDSA. So what is the complications? So complications mainly are prolonged of mechanical ventilation will be there. So there is a high chance of the pulmonary hemorrhage will be there, and long-term complication of bronchiectasis and parenchymal scarring leading to recurrent pneumonia is the complication of all these ventilator-associated and the hospital-acquired pneumonia. So the prognosis, current mortality rates as high as 50 to 70%. Okay, so very high. It's a very high mortality rate in case of patient with the hospital-acquired pneumonia and the ventilator-associated pneumonia. So all the patient that we are going to lose even in the COVID era is because of because patient is on the prolonged ventilation, and we are getting all these hospital-acquired pneumonia and the ventilator pneumonia and the addition of the viral pneumonia, and then we are getting the losing the patient because of this. So prevention, so avoid or minimize the intubation. So minimizing the micro aspiration. So this is elevating the head position. This is how you are going to prevent. Okay, so these are the importance of the prevention. So with this, I'm concluding the today's lecture of pneumonia. So it's better, so nicely given in your division. So read the division, and for the IDSA and ATS guidelines for the treatment of pneumonia, you can search in the Google also, or you can read the Harrison treatment portion of the Harrison of pneumonias. Okay, so this is how you are going to conclude. So in the important for the pneumonia is mainly a definition of common pneumonia. So what are the organisms and what are the investigations that you are going to, so how to differentiate between typical and atypical pneumonias, and then what are the complications of pneumonia and what are the treatments of the pneumonia, and then what is the definition of hospital-acquired pneumonia, what are the difference of ventilator-associated pneumonia, and the treatment protocol for the hospital-acquired pneumonia. So these are the important headings that you are going to read in the pneumonia. So in the next, I'm going with the tuberculosis, okay, on the next lecture. Okay, sir. If there is any question, you are free to ask me in Fiverr also. I know. So start reading. I know. Okay, problem, sir. CR okay, sir?
No, sir.
ठीक छ. So I'm going to ask you about the other lectures. होइन, so lecturesहरू भइरहेछ कि छैन मेडिसिनको?
भइरहेछ सर.
भइरहेछ. हिजो भयो? Yesterday lecture was there or not? मेडिसिनको लेक्चर भयो कि भएन? कामना?
सर भएन हिजो.
कसको थियो?
सर मुकेश सरको.
के भन्नुभयो? के कन्ट्याक्ट भएको थियो?
सर स्लाइडै सरको डिलिट भयो भनेर भन्नुभयो, अनि त्यही भएर भएन सर. हजुर सर.
अनि सागर सरको?
सागर सरको भयो सर.
सागर सरको भयो हैन? अनि के थर्सडेको भइरहेछ कि छैन बिहानको?
कुनको सर?
थर्सडे 8 to 9. थर्सडे कि बिहिबारको भएको छ कि छैन? थर्सडे यस्टरडे थर्सडेको लेक्चर भयो अस्तिको हप्ता? भयो?
इन्फेक्टिभ इन्डोकार्डाइटिस भएको छैन सर.
भएको थियो? थर्सडे भएको थियो?
भएको छैन सर त्यसको त.
त्यसको लागि सरले अब खाली भएको स्लटमा लिन्छु भन्नुभएको.
हजुर सर.
अनि कार्डियोलोजी लेक्चर भएको छ?
रिमेटिक फिभरको चाहिँ भएको छ सर.
अरु कुनै पनि लेक्चर ल्याएन? रिमेटिक फिभर मात्रै भएको छ? हो कामना?
यस सर.
अरु कुनै अहिलेसम्म अन्त भल्भुलर हार्ट डिजिजहरु कुनै पनि भएको छैन?
छैन सर.
छैन सर त्यस्तो.
हजुर सर छैन भएको सर
इन्फ्रारेड एन्डोकार्डाइटिस पनि भएन, एमएस पनि भएन, इसिजी पनि भएन,
इसिजी पनि भएको छैन सर।
रमेश सरले लेक्चर लिनु भएन अहिलेसम्म? I'm asking to CR. रमेश सरको लेक्चर भएको छ कि छैन?
भएको छैन सर।
भएको छैन सर।
के सरले पछि लिन्छु भन्नुभएको छ? के भएको छ?
हजुर सर हजुर सर त्यही भएको छ सर, त्यो पछि लिन्छु भनेर। अब लाइक अब के अरे फ्राइडेको पनि सरले चाहिँ सागर सरले भन्नुभयो कि हुँदैन भनेर। अनि भोलि चाहिँ हाम्रो के अरे 8 देखि होइन 3 देखि 4 भोलि लिनुहुन्छ। त्यही अहिले चाहिँ के अरे के भन्छ लिङ्क आउन बाँकी छ, त्यस्तै भइरहेछ सर।
ओके होइन, सो CR should give me the feedback.
हजुर सर नोट गरिरहेछौँ सर, हामीले नोट गरेर राखिरहेछौँ कुन क्लास बाँकी छ भनेर। अनि चाहिँ यस्तो ग्याप मिलेको बेला चाहिँ मैले कल गरेर होइन सरहरूलाई यदि टाइम मिल्ने भए चाहिँ गरिदिनु भनेर रिक्वेस्ट गर्दै आइरहेछौँ सर।
ल है, के प्रब्लम भयो भने लेट मी नो है।
हस् सर, सियर सर।
थ्याङ्क यू।
वेलकम सर, थ्याङ्क यू सर।